All right. Good. Good afternoon, everyone. Welcome. Not yet. It says it's on. Now? Oh, there. See? Good. All right. I was told I didn't have to do anything, which is in your favor. So, anyway, thank you for coming this afternoon. We're glad you're here. We think we have an interesting program. I know we've got a great speaker who's going to share some things with us. Before we get going, a couple things. For those of you who are here, thank you for coming, for be part of our live audience. We also have a live stream audience this afternoon as well, meaning that there's a video camera back here, and that'll be broadcasting. And so those of you on the live stream, this is the first time I think we've actually given this a shot. So if things go a little hesitantly, just hang in there. We'll fix things along the way as we go. One of the things that we get asked is sometimes, why do we hold these events? And an investment management firm like Foster Group, we've been fortunate through the years to work with lots of healthcare professionals, and we work with lots of people who need healthcare, myself included, and who will consume it over time. So it just seems like a good topic for us to get together and talk about. We're fortunate that we can kind of address both sides of that equation, and one of the things that we know for sure is the healthcare environment is changing. So it seems like everybody has an interest in that, and we're going to have a good time hearing about that this afternoon as well. Just briefly, a little bit about, for those of you who don't know who Foster Group is, we're an investment management firm here in West Des Moines, and we kind of just have three things we'd like to let you know about our firm. The first is it's important for us that our clients feel like they're truly cared for. The second is we try very hard to be a values-driven organization. And the third thing is we do the best we can to make sure that we're improving all the time. And if you want to know more about who we are, we'd be happy to talk with you afterward about that. We're really glad to have Dr. Tom Evans here this afternoon. Before I introduce him, though, I want to say there is going to be a question and answer session when we get done here, right when Tom finishes. And you'll, I think on your program up on the screen here, but the number is 515-497-0007. And you can text questions anytime during the presentation, and John up here and I will look at them, and we'll try to get as many of those questions to Dr. Tom here after he finishes making his presentation. So let me introduce Tom. Tom, as well as being kind of a healthcare expert, is also a very good longtime friend of mine, which means right now he's wondering if I'm going to really tell an embarrassing story, and I think I'll not do that for him, right now. But let me just give you a little bit about Tom's background. Tom is currently the president and CEO of the Iowa Healthcare Collaborative. And the collaborative focuses, I told him I would read this, focuses on provider-led initiatives to improve statewide healthcare performance through engagement of stakeholders, rapid deployment of best practice, and public reporting of clinical performance data. I think what I would tell you, what I know about the collaborative, it tries to bring together all the people who are stakeholders and interested people in healthcare within states to get better outcomes for everyone. And that's really what he's about and what our organization's about, so we're going to hear about that today. Tom received his MD degree from the University of Iowa in 1983. Go Hawks, I'm sympathetic to that. Completed his family medicine residency at Broadlawns in 1986. He practiced family medicine for 13 years and also served as the chief medical officer for the Iowa Health System from 1999 to 2005. And if those qualifications were not enough, I do know that Tom also served as the team physician for the Johnston Dragons football team for a number of years. Ooh. Primarily because he had to keep his son here healthy when he did stupid things. So, anyway, we're really glad to have Tom here. Tom, come on up. Thanks.
Thank you. We up? Tom? Hello? Kirk Enterprise? There we go. Okay. Good afternoon, everybody. This is going to be fun. At least it's fun for me. It was really weird kind of coming. I mean, I was expecting this big audience of people that were strangers that I didn't know, and now I walk in here and I've got Mary Kramer and Kay who are here, and Bert Sewell is here, and we talked about my residency program, so Larry Beatty, who trained me, is here, and just a whole bunch of people. Eldon Houston, who's the past president of the Medical Society. So a lot of good folks that have actually impacted me over the course of my life. What I want to do today, by the way, thank you, Kent, for that introduction. You read it just like my mom wrote it. I appreciate that. Seriously, today we're going to talk about some hard stuff. And I want to kind of think about the audience for a second. There's really three groups in the room here. There are physicians who are currently practicing, and there's a relatively small number of you in the room. There are a bunch of physicians who are no longer practicing, and then there are consumers in the room. And there are lessons today that really apply to all of you. A lot of this talk is stuff that I tell physicians today. Most of what we're doing, we are in a period of absolutely gut-wrenching transformation in healthcare, and it's going to impact all of us. So what I'm going to try to do is kind of walk us through some of the stuff that's happening, why, what, and then how does it impact us all. So with that, first of all, this is my commercial. I work with the Iowa Healthcare Collaborative. Can't mention I was with the Iowa Health System through 2005. I left the health system in 2005 and started the collaborative. This is a community initiative. We started working with hospitals and physicians and community members to try to figure out how do we make Iowa's healthcare better in 2003. And we got enough traction. We said, why don't we turn this into something? So it's a 501c3, and that's what we've been doing. Provider convened. What does that mean? Do you ever think about this with regard to healthcare reform? Healthcare reform. Who do you think has to do the reforming? Okay? Healthcare. I mean, basically the payers can't do it, the purchasers can't do it, the people who actually deliver the care, and we talk about reform, I would say in some ways it's really redesign. So what we're about is trying to figure out how do we do this differently and stay in business and meet the needs of our population. Like in a rural state like Iowa, those are big questions. So provider convene. We bring the doctors and hospitals together and basically say, look, and the community and the pharmacists and everybody else, let's figure out how we can work together to execute better care. We focus on not just quality, but quality, safety, and value, which means we need to actually do it more and more efficiently with each cycle. We concentrate a lot on performance improvement, but we also have information available to the public. And we don't just work in Iowa. You'll see later that we've got a couple of contracts. We work in multiple states. Matter of fact, for one contract, we're working with 15 states. So the stuff that we're doing in Iowa is actually impacting healthcare redesign in multiple states. And we've done some stuff that CMS thinks is pretty cool. So that's kind of who we are. What I want to have us focus on today, this is what we're here for. I want to describe why is this happening? What's going on with this healthcare reform? And I want to give you the guts of the story. Then I want to consider some of the key changes occurring in the healthcare industry as a result of that. And it's going to affect not just the provider community, but patients as well. And then one of the things that Alex asked me to do is, we have this one model we use called the Triple Aim, and it's about healthcare reform, healthcare transformation. But how's that going to affect us all from a financial perspective? How does our paradigm shift? How do we need to do this differently? So let me move into the Triple Aim here. This is a Venn diagram, and it basically says we have to do these three things at the same time. Now, if you're a provider, we're all out about doing care and doing better care and getting better and better, and we know that. We deliver care. If you're CMS, if you're the Medicare, if you're Wellmark, if you're an insurance company, you really have always just been focused on these bottom two circles. I got to get those providers to deliver the best care that they possibly can, and I need to be a good steward with the dollars. So it's been this constant for the last 30, 50 years. It's been about how do we navigate this based on a financial model, fee-for-service type of a model. The interesting thing is our system in our country is unsustainable. We can't keep delivering care the way we have unless we want to start just printing money. So with that, we've come to the recognition that just trying to deliver, if better care is fixing broken people, that's good. We fix broken people. But if we're really going to bend the cost curve as a country, we need to start thinking about keeping people from getting broken as well. So how do we create healthier communities in addition to fixing the broken people and doing it so that it's more cost effective and it doesn't break our country? This is called, this little thing on the bottom, it's called the Triple Aim. But there are national applications of this, there are state applications of this, and actually in your personal community applications of this. Marshalltown, Ida Grove, whatever. How do we do it here? Okay? So I spend a lot of my time working in the state and the national arenas. Now, they call this the triple aim, and I like this slide because this is what we're trying to do. We're trying to hit those 3 targets with the same arrow. We've got to do better care, and we've got to build healthier communities, and we've got to do it with the dollars that we have. So with that, a couple of questions I'd just like to have you think about. I mentioned there's multiple populations here, but for the providers in the room, those of you who are in practice, what is happening? What's happening to me, and what should I do now? How do I act with this stuff? For the patients or for the retired physicians in the room, first of all, for the retired physicians in the room, you're going to be looking at this and you're going to be going, I'm glad I retired. Foster group, how was my money? That's one thought. Now, but the second piece on this one, for patients, I usually don't give presentations where I'm talking to the patients, but I really am talking to the patients today. I want you to understand what's going on in the healthcare system because you are going to be one of the most important parts of the healthcare system going forward. We all have to assume responsibility for healthcare costs now. So what is happening to the healthcare system? You need to understand why, and I'm going to give you some pretty direct financial descriptions of what's going on as a country. Why should I care? And here's the big one. What should I do differently? How should I perform differently? So those are things I want you to kind of have in the back of your head as we go forward. The future. We're always looking to the future. The fact of the matter is, though, that decisions have been made in the past are not creating a future that is something that we can actually continue to execute in healthcare. What I want to do now is just give you some slides, some economic slides to help you understand where the United States is with regard to healthcare and why this is such a big deal. Why are we hearing this so much? A couple of things. As we move into the future for healthcare, it's important to recognize some changes that are going to be in the new healthcare future. The first one is the world is going to be transparent. The way healthcare systems today, if we have data, usually, and I was Chief Medical Officer of the health system at Iowa Health System, I was in charge of quality and patient safety, and I can tell you back then when we were doing it, we generate data and we go, look at this. Look at this. We should now put this in the paper and tell everybody how good we are. We used our quality data for marketing or for comparing if we were better than somebody else. We didn't really use it for improvement. We didn't really use it to say, oh, let's use this data to now drive what we're doing. So the data, there's going to be more data available, and there's going to be an expectation that people are using the data both to inform consumers about how effective the care is and also to do performance improvement. Number 2, zero harm. What does that mean? Is that achievable? Well, first of all, it's important for you to realize that for many, many years we didn't even acknowledge that there was harm. Something would happen to a patient, oh, that poor patient. They got an infection, oh, that's a bad outcome. You know, now we recognize that there are so many things in healthcare that we have the ability to bend the curve on. Certain things that if we do them differently in the inpatient arena, we won't have that harm happen. Those are called unintended consequences. We now know enough about the science and the measurement in healthcare that we're working to actually prevent harm, build processes in from the front end so that the bad things can't happen. The expectation in the future, the idea is that we have zero harm. The last one is adaptability. I got to tell you, the way physicians are trained, we go to medical school, then we go to residency, and we learn how to do this, and then we go out into practice and we turn the crank until people quit paying us to do it that way. We try to keep up with CME and stuff, but the bottom line is we aren't particularly adaptable. The future is going to be about being adaptable. Constantly using performance improvement to change the way we do what we do. How do we manage the population? How do we do these surgeries? How do we do this stuff? So these are the design principles for the future. And I think you're going to hear these more and more. How do we get there? There are 4 things that we're focused on today. They're changing the way that reimbursement is. It's no longer going to be strictly just fee for service. How many widgets did I generate? It's going to be now you're paid for a population, and how effectively I cared for that population will determine my reimbursement. There's going to be pressure to have more and more of the community and the providers aligned in care delivery. It just feels like small town Iowa because we kind of sit here and think, okay, the doc and the town, and we do all this stuff together. But for the most part in healthcare, usually the doctors and the hospitals just tell you what to do. and the providers in the community are really kind of separated on care delivery. In the future, matter of fact, the future is now, we're working to find more and more ways where the communities begin to define a standard of care, and everybody's working to create a higher standard of care in their local community. Care coordination. We used to talk about this, and I used to think of it as primary care and specialty. I'm a family doctor by training, by the way. So primary care and specialty, are we coordinating the care? It's so much bigger than that. It's primary care to specialty care. It's family physician to pharmacist. It's hospital to long-term care, nursing home. All of these are care coordination opportunities where we drop the ball so often and we create unintended consequences and we create cost. So there are going to be expectations that we now start playing with healthcare as a team sport. And the biggest thing, especially for a state like Iowa, is sustainability. You may not know this, but Iowa is one of the most efficient states in the country with regard to healthcare delivery. We have relatively high quality when you rank us out with other states, but our reimbursement is relatively low. Now, the way that you measure value is quality divided by cost. So we're a high value state. Great, what's that mean? It means now we're moving into a value-based reimbursement system. We already have low reimbursement. And now, it's not like we can make it up on volume. So what does that do to the delivery system in a rural state? Are we going to put the hospitals and the physicians out of business, and then we, the consumers, won't have access to care? So those are things we need to be thinking about as we redesign a healthcare system in our state. Now the financial slides. I apologize, these are a little hard to read, but I'll describe them to you. This one, you kind of look at this, it looks like a wiring bundle from a 747, and then there's one wire that goes off to the side. This is the 33 most developed nations in the country. I'm not going to read off all the list there, but you see there's one country that goes beyond everybody else. And basically, this is the percentage of our gross domestic product spent on healthcare in our country. What does this mean? Well, now wait a minute. We're the world's richest country, right? We can afford that, can't we? Can we? Because every one of your purchasers, your manufacturers, have to pay for health care, and they have a higher percentage of their cost of building product just to be able to do this. We're competing in a global economy today. In the United States, our manufacturers have to compete they have a real disadvantage there. By the way, this was okay in 1970. Because in 1970, the United States made about 67–70% of the world's gross domestic product. Today, we make about 34% of the world's gross domestic product. We have to compete in a global economy. So this is one problem, but okay, the next one is actually more bothersome. This is a series of pie charts that look in 3 different time segments: 1970, 2014, and 2040. And what I usually do when I'm describing this, look at the Medicare wedge, which is the orange wedge there. And in 1970, what percentage of our federal budget did we spend on Medicare? In 1970, it was 3%. In 2014, it had grown to 14%. And the projections are for 2040 that it's going to go to 20%. And you go, oh my gosh, that's terrible. Well, but wait a minute. The baby boomers are coming of age. We're getting older. I guess I can kind of build. That makes sense. Okay, I'm not so worried. Okay, we'll think about this one. Let's look at social services. The top line there, Medicare, Medicaid, and Social Security. So the orange, the green, and then the dark blue. 1970, 20% of our federal budget was spent on taking care of ourselves. 2014, we're up to 48%. 2040, projections are close to 60%. That's a lot of our federal budget just taking care of ourselves. Okay, well, let's consider one other thing. What about the red wedge? I call it the red wedge. It's really the red area. What's in the red? Well, we go from 73% down to 46%, down to 27% for projections. What's in the red wedge? Transportation, education, defense. Have a nice day. You want to guess why we have a federal deficit? Because these are things we can't not buy, right? Now, if none of that bothered you, This next one is the one that actually bothers me the most. Look at the light blue. The net interest. This is what the federal budget is paying on our national debt. In 1970, 7%. In 2014, 7%. Projections for 2040, 17%. You want to know why healthcare reform is such a big deal? You now get it. We've got to figure out how we take care of ourselves more efficiently, or we're going to break ourselves. And for those of you, again, a lot of old docs in the room, we've all heard this stuff before. We've heard it for years. Heard it. Why now? Why is it so important? This is why. 30 years ago, and we kicked the can down the road for 30 years. We can't kick the can down the road anymore. We're going to break the country. So one other slide I want to give you is, okay, so this is how much we're spending taking care of people. This is how much we're spending fixing broken people. Well, if we're going to not fix broken people, if we got to find some way to reduce the cost, how can we get more efficient at fixing the broken people? I mean, is it just that the doctors and the hospitals have to do a better job and be really diligent and don't waste anything? Is that the deal? Well, it turns out there are other things that drive healthcare cost. When you look at the things that actually drive the healthcare cost, all of our dollars, this Healthier Communities thing, it turns out that green wedge is clinical care. 20% of the cost and the improvement opportunity is really in healthcare. If the hospitals and the physicians did this perfect, we'd bend the cost curve by that much. So where are our real opportunities? It's in the building healthier communities. So what do we have up here? Well, the green wedge, 20%. Now, physical environment, do we have, is the water safe and is the air quality good and all that kind of stuff? That's about 10%. But look at the other two, real opportunities. Patient behaviors, 30%. Smoke, obesity, compliance, do you do what you're supposed to do? I mean, all those kinds of things. About 30% of the opportunity is just in us engaging the patients as activated partners in care delivery. Okay? But look at the other one. There's another 40% that are driven by social and economic factors. What does that mean? Those are called social determinants of health, and there's basically three big categories that are driving healthcare cost. Safe housing, transportation, and food security. Now, I'm not trying to sit here and sound like some big public health guy or something, but it is important for us to realize as a society, if we're going to bend the healthcare cost curve, if we're going to build healthier communities, we're going to have to start building healthier communities. So that's the reality with regard to the financial situation. And I mentioned earlier that value is, again, quality divided by cost. Some of you, again, there's some older physicians in the room, you remember in the 1990s we did this already. We went into capitation. Whoa, we're going to do all that value-based stuff. And it didn't work. It didn't stick. It'll go away, right? Wrong. First of all, it didn't work in the 90s. You want to hypothesize why? In the 90s, we couldn't really define quality. We didn't really have evidence-based medicine, which really started in the mid-90s, and it wasn't really embedded in constantly doing better and better care. So in the 90s, what we had was value was 1 over cost. The only way we could measure our improvement was just to reduce cost. And after a while, patients started to say, excuse me, I'm going to get sued. We can't do this. And the other thing they began to say is consumers began to say, excuse me, this isn't good care. So we backed away from the managed care days. In that time, we've spent the last 15 years developing the ability to measure and drive quality. And we're at a completely different place. It will stick this time. I like this slide because it's so illustrative of kind of where physicians are today. Physicians are on this volume-based treadmill running as fast as they possibly can, chasing this ethereal thing called value. I can't tell you how many times I've been in front of a medical staff and I've talked about value and they go, yeah, God knows what that is. Okay? It's very hard. It's been tough to define historically. What the federal government is doing is basically delivery system reform. They're using 3 levers. They're going to start paying physicians differently, providers differently. They're going to be working with us to change the way we deliver care, but the information is going to be distributed as well. So the federal government, remember I mentioned transparency earlier? The federal government has basically said, we're going to start posting your claims data, and so everybody can look at this. It's the new transparent world. Now, this is what I live every day. People who every bit of their DNA is trained in a volume-based healthcare system, trying to figure out how to now play a completely different game. And it's not easy. I like this. This is a metaphor I'm going to use. I've used it for about 10 years here. But if you look at the volume-based healthcare system, everybody understands volume-based. If I go to the muffler clinic, they're going to fix my car and they're going to do stuff, but it's did they buy a clamp? Did they, whatever they did, but it's volume-based. It's eat what you kill, and that's what healthcare has been based on. And if I had to say healthcare, if healthcare was a sport, if the financing system for healthcare was a sport, it's been fishing. Now think about fishing for a second. We all get in the boat, 7 o'clock in the morning, we go out in our boat, we put our boat where we want to fish, and we fish as hard as we can all day. We come together again at about 3 o'clock and we compare how many fish did you catch, how big are they, and we see who wins. That metaphor works for family physicians, for general surgeons, for hospitals, for long-term care, for pharmacy. That's the healthcare system. That's how we're reimbursed. By the way, that's a 28-inch walleye, just so you all know that. And it's not the biggest walleye in the world, but it's the biggest one that I've caught. So I thought you guys like to know that, just for me. Okay, so now that's fine, but this is the way our providers are trained. Catch fish, catch fish, catch fish, go, go. Matter of fact, what's funny now is when I go around and I try to train physicians on how to do performance improvement, they kind of, I've actually had people say, so how many of those quality things do I have to do? Now you realize how crazy that is, because frankly, if you're doing value-based things, you probably don't need as many, okay? You haven't done them. So it's important, and people have been trying to figure out how do we do performance improvement in a volume-based system, and usually what happens is we try to work faster, we try to work harder, we try to work more sincerely, we try to generate more volume so that we'll be good physicians and we'll be bringing value. The fact of the matter is that's backwards. It doesn't work, and if you're actually managing the resources the way you do, the fishing metaphor just completely unravels. So if you're really going to think about value-based reimbursement for physicians and for clinicians and where we're trying to get people to go, it's no longer fishing. And I'm just going to use the metaphor. It's really about football. Now, remember, value-based reimbursement is that me, my clinic, my hospital, my system is going to assume risk for a bunch of patients, and we're going to get paid ahead of time. So now we've been paid, and now we have to take care of them, and the goal is to keep them well. We don't want them to be sick. We don't want them to generate charges. So it requires us to work together in completely different ways. We can't just have everybody fishing as fast as they can here because it's going to burn the dollars. So how we work together in the value-based system is much more like football. Imagine football. You got 11 people on the team. You only had one in the boat before. You have 11 people on the team. All of those, oops, there, sorry. You have 11 people on the team. Everyone is going to run a play. That means that out of those 11 people, they're all different. Some people are big, some people are small, some people are fast, some people are strong, but everybody has a different contribution that they bring to the team. The next thing is the care is coordinated. When the ball is hiked, people don't just kind of, okay, what do we do now? I mean, they don't just do that. Everybody's got a specific thing they go and they do at that time. It's coordinated. They start at the same time, they stop at the same time. They run exactly this place, they do that stuff. It's collaborative. People have to work together to bring the most value. If two guys have to block for another guy to carry through the hole, that's what we're talking about. And the other thing, probably the most important thing about this is the value system, the reward system for the football team is linked. Those 11 people with each play move down the field together. They get penalized together. They only win the game together. It's important for people to realize that as we move into this value-based system, if we're going to bend the cost curve, it's going to take all of us working together to bring efficiency to the system. This looks complicated, right? I want to tell you now, what does payment look like in this world, and what's the federal government doing to us to try to help us move into this football model versus fishing model. This ladder, there was a piece of legislation passed in 2015 called the MACRA legislation. And it basically, it introduces pay for value into the physician reimbursement world. What it's done, and this is really the beginning of a process that's going to go about another 15 years. I'll show you a timeline in a moment. But they basically said, we're going to pay you guys now based on value. You can decide how you want to participate. You can do a lot of value or a little value or no value. So imagine this ladder here, again, moving from fishing to football on the risk, volume to value. You can contract for whatever risk you want to take. But everybody has to at least go to step one, which is merit-based incentive payment system. What does that mean? It means you're still doing volume, but you got to send quality data in. And that quality data will be compared with a bunch of other physicians. And if your quality data is really good, you can make a little more. But if your quality data isn't something that distinguishes you from them, you're in the middle and you actually could lose money. So that's level one. Now, if you want to actually begin to take additional risk, and there's several ways that you can take it, level 4 is like full risk, you actually have more opportunity to earn more money. If you want to assume risk for a population and manage it very aggressively, you can actually make more money than you could have in the old world. This slide, and I apologize for the busyness of this, but this gives you where the federal government wants to go. Now, look at these circles and imagine the size of the circle is driven by the number of people doing it. And I want you to look at this side over here, the left side first. Category 1, 2, 3, and 4, those are the steps of the ladder. Category 1 is just fee for service, no link to quality and value. That's where we are today, current state. Most people are in that kind of a system. And then we have a few people in Category 2, which is fee for service, giving some quality data. Category 3 is advanced payment methodologies built on a fee for service architecture. And Category 4 is like full risk, Kaiser Permanente type of coverage. The reason this is important to you is look where the federal government wants to go with a future state. They want to move the big orange circle to a little dinky orange circle so that fee-for-service medicine is really very small, and providers are incented now to aggressively manage populations. Remember step 1 here, merit-based incentive payment system, okay? Taking risk. I don't want to take risk. I don't trust this stuff. I'm just going to be where I am right now. I'm just going to stay in MIPS. Okay, go ahead. Stay in MIPS. So I'm going to stay at the low end here and not do too much. That's fine. What I want to do is kind of build the case that the federal government's kind of gently going to push us uphill here. This is the timeline for the MIPS payment adjustment system. So in that macro legislation, remember, is federal legislation passed by the Congress of the United States. This isn't like a little test program. This is congressional, this is like the law of the land. And notice what happens here. You've got this timeline across the top, 2015, 16, 17, you go all the way to 2026. This is written in federal statute, okay? Now, what happened was this thing really it went live in 2015, and then the first payment stuff really hit for physicians in 2017, and they started gathering data. So in 2017, the start of MIPS for the 2019 measurement cycle. So they're saying, okay, 2017, 18, we'll take your data, and we'll try to get an idea of how good you are, and then it's going to affect your payment in 2019. That would be January 1st of this year, okay? What happens on January 1st? Well, based on how efficient you are, remember we said just send us some quality data and we'll rank you out and we'll see if you're better or worse. What's the reward and penalty system? In 2019, you got an upside downside of 4%. So that's all of my Medicare charges. I'm at risk. I could get a 4%. By the way, all physicians think they're going to get the 4%. Okay. It's interesting. Whenever I ask physicians, I get in front of a medical staff like this and say, okay, how many of you practice in the lower 50th percentile? No hands go up. Never. None. Okay? Well, let me change that. Once. In South Dakota, one hand went up. This guy goes, just kidding. So the point is that we're a very competitive group. No one thinks this is really, that they could end up with a 4% penalty, but they could. Now, look how aggressively this goes. That's 2019. And for 2020, now we're measuring 18 and 19. Oh, look what happens in 2019 or 2020, upside downside 5%. 2021, upside downside 7%. 2022 and beyond, upside downside 9%. And all they have written in the statute is through 2026. Now, for those of you who think this isn't really going to happen, I think it's important for you to realize healthcare reform, this didn't just happen. This actually started in the mid-'80s. And we've been doing things, and frankly, if you look at, I mean, when is this going to be over with? Think of it as mid-'80s to probably 2040. Okay? We will come to an end. We will transform the healthcare system, but we're kind of at this 2/3 point now, and what's happened just in this decade is all the stuff we've been doing as pre-work, they attached it to physician payment now. So where we are right now is with the Affordable Care Act, which dramatically impacted hospital reimbursement, and the macro legislation, which is dramatically impacting physician reimbursement. Now it's like we had to do all this pre-work, and now we're actually going to put this thing in gear. So that's what's going on. One of the things that I work on, and actually Dr. Beatty is in the room here, he actually worked for me a while on this project, but we have a federal contract with a bunch of physicians, 8,000 of them across the country, to try to help them learn how to do performance improvement. So if I got to now survive in a value-based healthcare system, how do I do that? Well, I don't know how to do it. They didn't teach me performance improvement in medical school. So we work with these physicians. This program actually is called Transforming Clinical Practice Initiative, but we help them to go through 5 phases, help them to set aims and then begin to gather data to inform their practices on how they're doing on those aims. And then we actually get to the one, we're so happy when we get to phase 3 because, oh my goodness, our numbers are actually improving. You should see the enthusiasm pop up then. It's like, whoa, this works. Then we take them to phase 4, which was, you now are getting numbers that are good enough that you can compare with other folks across the country. You may even be at the top of the deal. And the goal is that if we get them into phase 5, they can do this with lots of different areas in their practice. They're probably ready to start assuming risk. So the trick is to try to get those practices to that point. The Iowa Healthcare Collaborative, we started signing up all kinds of other states to do this work. So even though I'm the Iowa Healthcare Collaborative and we're kind of the lead organization for this, we formed this organization called Compass PTN, Compass Practice Transformation Network, and we have 8 partner states in the, I think it's 8, yeah, 8 partner states in the light blue, and then the dark blue states are places where we have physicians and clinics that are contracted that we're working to try to equip them with this stuff. What are they trying to get us all to do? What are we trying to get practices and physicians to learn how to do in value-based reimbursement? What does it mean? These are the goals of the campaign. Not to work with all 1 million providers across the country, but to work with a pilot group of 140,000 and try to actually improve health outcomes. We're going to track it with regard to Medicare and Medicaid and all that. So that's nice. But basically, the job is to actually make care better. If you're diabetic, is your hemoglobin A1C better? Do we have fewer readmissions to the hospital? Do we have fewer adverse drug events? Do we have fewer falls in the hospital? Do we have fewer pressure ulcers? Improve care. We want to reduce unnecessary hospitalizations. We want to generate savings. We want to reduce unnecessary testing and procedures. How many times have you had the same thing done again and again? How many times do I need that chest x-ray? How many times do they need to get this one lab test? That's waste in the system. Can we get efficient on this stuff? We hope that with this program that we want to transition 75% of that 140,000 into that level 5. And we hope that we're going to build a knowledge base that we can take this information. CMS will build this into the reimbursement system going forward so that we can actually equip people. Remember, our job here is not just to transform the practices, but have them be able to thrive where they are. We don't want to sacrifice the access to the healthcare system. So, kind of bringing this home, I know Alex is back there probably ready to throw something at me here, but let's bring this home. Today, what the world is like, fishing to football really defines the clinical world today as they're transitioning. Point number one. Point number two, we have resources in healthcare, but we need to start coordinating how we use them to reduce the waste and duplication in the system. Number three, we need to work to create high-functioning teams. I want to go back to football for a second. Kent mentioned that I was a team doc for Johnston for 20 years. And I saw a lot of football. I saw some good football. I saw some bad football. I can tell you right now, just putting on the uniform doesn't make you a good team. I can tell you, putting on the uniform and actually running around or doing push-ups doesn't make you a good team. It's the execution. You can pull together the team. You can get the kids in shape. You can actually have them drill. But until you actually get out and have to execute against somebody else, and my biggest lesson in 20 years with healthcare, and this is the following. By the way, Johnston always got tarred for years and years and years. We just were terrible. Not now, but back then we were. And I still remember Newton. Newton would come to town. Newton would come to town, and they were just a little bit smaller than us. They would kill us every year. They'd clean our clock. And I mean, I was team doc long enough, I got to kind of figure out what was going on, but I was going, Newton only runs 7 plays. Now, the interesting thing is the senior high would come in and they only run 7 plays. The junior high would come in, or the junior varsity would come in and they only run the same 7 plays. The sophomore team only ran the same 7 plays. The 7th grade team ran the same 7 plays. But what they did is they did it to perfection. It was about the execution. It doesn't take a complicated system. It takes a coordinated system. It takes people knowing what they're doing and working on efficiency. So, and then again, I can't underscore enough, this is no longer just about the provider community fixing broken people. It's about engaging our patients as activated partners in this process. That's the only way we're going to bend the cost curve. So this is usually what I'm telling the docs at this point because they're depressed. But the fact of the matter is physicians today have a choice. You can either be a cog in a machine or you can be the cog that's driving the machine. And my encouragement is for you to step up and be the cog that's driving the machine. The other thing I would tell you is that we need to be focused forward into the future, leaning into the future, not, oh, those were the good old days. Remember when we got the, we can't do that. Those days are gone. We can't print money anymore. We've got to be efficient. And then finally, just the encouragement to lean into transformation. Master the skills, get good at it, and bring others with you in the journey. So, why are we here? We got to hit this thing. We have to hit this thing. We've all got to hit the triple aim. Better care, healthier communities, and smarter spending. This is just basically reminding us all that this applies to everybody in the room. We need to be focusing on actually making sure that the care that we receive and we participate in and we deliver is the best care. We need to be focusing on building healthier communities and encouraging people to be healthy. And probably most importantly, we got to be thinking about the dollars. This is really twofold. Number one, how efficient is the care that I'm receiving? And now this is back to the young physicians who are coming out today. It used to be that we would go out and we'd take out a bunch of debt, we'd buy a car. We never had to worry about the money because we could always make it up on volume. Not anymore. You better be thinking about your financial status. You better be thinking about your stewardship of your resources as you go forward. So bringing this in for a landing, I like to close this with a couple of talking heads that really kind of tell us, since we're depressed, I thought I'd bring you some jokes here. But the first one isn't really a joke. The first talking head, anybody recognize this guy? I mean, some people are going, well, wait a minute, that's a joke. And I'm just saying, hold it a second. The reason this slide is here is not to advocate for President Trump or advocate against President Trump, but it's to remind us all of something. President Trump right now is responsible for the system to transform it. He can't run from this. They couldn't just unravel the Affordable Care Act. President Obama couldn't run from it. President Bush didn't run from it. President Clinton couldn't run from it. President Bush, other Bush, also. Every president since President Nixon has been wrestling with this issue. Obama did some things, Trump's doing some things, Bush did some things. You know, Bush pushed us into information technology. He drove the healthcare community into information technology. Obama said, we got to do something, and basically used the Democratic trifecta and smashed through the Affordable Care Act, which gave us something to react to. The interesting thing is the Republicans now have a Republican trifecta, and they tried to repeal it. Everybody notice how well that went? You know why? It's not that the demon Democrats wouldn't have this happen. It's because they didn't have a better alternative. We've got to figure out how we bend this cost curve, and at least the Affordable Care Act does some things. This is not a partisan, I don't care who's president right now, but I know whoever is has to continue to drive this. So some talking heads to kind of wrap up here. This is about change. And this is what we've got to live with. So the first one would be Bill Gates. We always overestimate the change that's going to occur in the next 2 years and underestimate the change that's going to happen in the next 10. I can't tell you how many times I've seen that just recently. With this macro legislation, everybody was freaked out about what their 2019 reimbursement's going to be, up or down 4%, and they're missing the point that by 2026, they will have had 4 years of up or down 9%. You need to be focusing. I like this one too. George Carlin, you may recognize him. I don't believe there's any problem in this country, no matter how tough it is, the Americans, when they roll up their sleeves, can't completely ignore. You realize that's what we have done for 30 years. We have kicked the can down the road multiple times with regard to healthcare reform. And now we're at a point where we can't do anything else. We've got that 17% thing. You may as well tattoo it on all your foreheads. This is not going to go away. We need to figure out how we address this. Everybody's heard of Winston Churchill. This next quote, I need to give you a little context. Remember, in World War II, Great Britain was getting their head caved in, and they were trying to get the United States to get involved with World War II. Get involved, get involved, get involved. And Churchill had to keep telling the British, it's okay, they're going to be there, they're going to be there, they'll get there. And I love this quote, the Americans always do the right thing after they've exhausted all the other alternatives. And that's pretty much what we did in World War II. It took Roosevelt a while to kind of get to a point where the rest of the Congress would go, oh, there's nothing else we can do. I guess we better go help Britain, okay? So another one here is kind of on us. This is Jerry Garcia from the Grateful Dead. Somebody has to do something, and isn't it just incredibly pathetic that it has to be us? Okay? I mean, I hate to tell you guys this, but we are the generation that has to do this. So we got to, and I don't care if you're a consumer or a provider, that's what we got to do now. The last one, anybody ever heard of Peter Drucker? Okay, the godfather of business wisdom, and I like this. I actually added this because I saw it recently and I think it's so important. The best way to predict your future is to create it. And it really, really underscores what we have to do in healthcare today. We have intelligent people, tremendous great spirit. We've got a good healthcare system that's high value and is doing a great job with our community. Now we got to go out and rebuild it. So how do we do that? And it's going to take all of us doing it together. So I'm going to stop there and turn it over to Kent.
All right.
Sorry, kind of abrupt.
No, that's all right. Tom, you get to stay up here because we're going to, thanks for doing that. We're going to try to get some questions here. We've got a few that you guys have sent in.
Perfect.
So which chair would you like?
I don't know. I'm going wherever you tell me.
Good, you're good. All right.
I feel like I'm on the Johnny Carson show.
Yeah.
You guys
I'm not
are
going to
waiting.
respond to that yet. So, thank you for your questions. We'll see how many of these we can get through in a little bit of time that we have.
Crap. You really have questions?
I do.
Oh, no.
And they really sent them.
Oh, no.
It's really encouraging.
I looked at you guys, I thought they won't know how to do that texting thing. Didn't work. Okay.
Yeah, so here we go. So one of the first ones that came in was just the idea, you mentioned how efficient Iowa is or how much value we provide. So the question was, so if we're so valuable with providing high quality care at a lower cost, would it be helpful to look at states that aren't providing that value and restrict their payments, kind of put them on a forced diet?
Yeah, that'd be cool. I remember in 1988 going to Washington and building this case. I remember being in congressional offices and and I remember talking to CMS, and they basically go, well, you don't realize we want the rest of the country to be like you. And by the way, those people in the bad states vote too. So it's kind of hard to just pull the money away from Mississippi and Louisiana, who are very inefficient. So, you know, Iowa and the upper Midwest is very efficient, and the southeast and the south central part of the United States is very inefficient. But it would be, but that would be too easy.
So just to follow up on that one, so I've thought about this before. You talk about the upper Midwest being more efficient or high value in other states. When you think about your three circles on there in terms of the trifecta, is there something to do with any one of those particular circles that makes the upper Midwest just a more value-driven
It's good news and
setting?
bad news. There are two pieces. I think that one of the things is that we're very community-minded. We work together. We really get. You know, I joke about the Iowa Healthcare Collaborative. I've told the story of the collaborative in many other states, and they go, "Oh, that's cool. We could never do that here." And the reason is because here there's a degree of goodwill and camaraderie and working together. I don't know. It's because we all built barns together and put up fence. I don't know what it is, but it's the way we do things in Iowa that makes us willing to do the right thing and to work together to do the right thing. Now, it's not just Iowa. The upper Midwest, maybe it's because we all have to go through winter together. I don't know. But Minnesota, Wisconsin, Iowa, the Dakotas, that whole area tends to be very community focused. And so that's point number one, is we naturally are hardworking, cold avoiding people. The second thing, though, that's interesting, there's an interesting historical piece in that in 1966, when Medicare and Medicaid were kicked off, they didn't know what the rates were going to be. So they kind of took your claims and they kind of said, well, it looks like Iowa kind of is down here and Louisiana's kind of right here. And so they kind of started locking them in and then moving over time. And after they had several years of data, they could kind of put in trend lines. And what happened over time is we found that Iowa was a very efficient state. Iowa had a lower rate of growth, and some of these other states, oh, they must be sicker. They must, you know, we weren't very sophisticated in establishing the claims basis. But so Iowa has for years lived with this, for many years, like through the 80s, we were on a lower rate of price increase than some of the other states. So now they've adjusted a lot of the stuff and it's a lot closer, but still we have disadvantages because of our historic efficiency and effectiveness in care delivery. We have done a good job over time and it's ended up biting us in the backside for reimbursement.
It's a cautionary tale.
Sorry. Don't do the right thing.
Yeah. So you talked about moving from the fishing picture, nice fish.
Thanks.
Yeah, yeah. To the more team-based thing. One of the questions that came in was, how do you do that? I mean, how do you move from a system that we're in now to more of a team-based deal? And when you do that, I think the gist of the question was, and still maintain some degree of individual accountability for the people who are on the team.
Well, again, it depends. And again, I'm a family physician, so because I'm doing a lot of different things. I had a lot of people doing different things, and I was really kind of focused on maintaining the health of a population, my patients. But what if you're a specialist? See, that's what I mean by it. It kind of, if I'm a specialist, I only fix broken people. So how do I do that most effectively and efficiently? I wish I had the answer, other than the systems are going to evolve where, at least what we're seeing happen today. Imagine the Iowa health system as an accountable care organization. This thing has assumed risk for a certain number of patients, and now it has to maintain the balance between the hospital, the primary care, the specialist, and all these other pieces, and it has to manage all that so that it provides the most effective and efficient care for the population they're managing. I wish I had a simple answer, but there isn't one, because each one of those folks will have a different, just like the football team, everybody's got a different role. The split end only runs down and catches a touchdown like not very often. A lot of the time, he's just running around. So, you know, everybody's got a different role. I don't know if that got where you wanted, but
I don't know either.
that's the best I can do.
So you had that ladder at the bottom, I think, was a payment schedule called the MIPS schedule, so kind of you could stay there on the value, on the volume-based
You could stay,
approach,
you could
right?
stay at level 1. Yeah.
Okay, so question was, what are the potential upsides and downsides to staying at that level?
Okay. Upsides. I don't have to change. I can just stay here. Matter of fact, I don't want to do all that quality stuff. As a matter of fact, I'm going to retire in 2 years. I'm not doing this junk. So predictability, I know what I'm doing, that's fine, that's fine. But the problem with that is it's sort of like, okay, I'm going to play for a little while and not have a lot of risk and get out of here. That's really what's going on. If you're going to win at MIPS, you have to, you continue to do fee-for-service medicine, you identify a couple of measures that you want to send into the federal government, and then you hope, because the federal government say, I'm going to send in my diabetes care. This is my numbers, I send them in. The federal government says, oh, here's Tom's diabetes care, and we'll put them in the diabetes care pile. And then they at the end of the day, they look, take the diabetes care pile, and they say, okay, the top 10% get an extra something. And then there's a lot of people don't get anything different, and then the guys on the bottom, we're going to take from them, okay? So, and we're just learning how to do this, but remember the upside downside of 4% for year 1? Well, the numbers are out. The maximum downside was 4%, but the maximum upside was only 2%, okay? And it turns out that there were so few people that were exemplary, and there were so many people, well, excuse me, let me do this differently. Out of all the people that reported, everybody reported their best measure, right? I want to send in my best measure. So everybody sent in their best measure. So now everybody is up at the high end of performance. And then when they tried to carve this thing up, they had a whole bunch of people performing high. So there wasn't anything to spread across so many people. And the guys down at the bottom, they lost their money. So bottom line is, I wouldn't want to stay at MIPS. I think MIPS is a good place to kind of learn how to do performance improvement. It's a good place to start, but I wouldn't recommend any primary care physicians stay there. Specialist physicians may want to stay there for a period of time, but anyway, that's where I'd go.
All right, a couple more here. This question is about Medicaid. Just, I think the idea here is anyone really measuring it effectively, both in terms of how it's being used and how it's being paid for? Who's looking at that?
Okay. That's a complicated issue. Okay, Medicaid.
It's a very short question.
Very short question,
Yeah.
complicated issue. Medicaid, we went from having the state-run Medicaid program and each year having kind of an uncontrolled increase. You were a legislator, your mom was a legislator, you know as well as I do that Medicaid was the one thing that always just blew your budget out. You never could predict it. So we went from this, and Governor Branstad got convinced that we should just cap off the cost for Medicaid and give it to companies to manage. So they said, okay, we got to balance the budget, so we're going to put it into a managed care, and the managed care companies will now assume the risk, and then it'll be their problem if they don't manage this effectively, and we protect the state. That was the original thinking. What's happened is, obviously, it was a very unpopular move. Talk about a polarizing discussion. Back on your counting issue, there was one accounting firm that did the initial number calculations, and then when we brought the new Medicaid guy in, he wanted to bring in somebody else. So now we went from Milliman to somebody else, and somebody else's numbers came back. And so our performance went from this to like this, depending on how somebody measured it. Okay? So remember, these are just gross estimates anyway. So the methodology changed, so they are tracking it, but I think it's important for people to realize that the way that they're actually measuring it changed, and that's what's going on today. I don't want to be an advocate for or against the Medicaid managed care model. But remember that a managed care model is basically the insurance company is taking risk and leveraging the provider community to do things differently. They pay me based on, they give me incentives to do things. They pay me. An accountable care organization is when the provider community comes together and takes the risk. And now the provider community actually has skin in the game and is really concerned about how do we do care coordination, how do we do performance improvement. So that's why a lot of the, like Unity Point and Mercy Health Network and others are building accountable care organizations to play football together.
Okay. One more question and then we'll let you go. All right, so this one has to do with, and this is actually, it gets a lot of, there's a lot of questions, it seems like, that I hear about this as well. How does improving mental health reimbursement fit with this model of care? I love that
Thank you for a little
Save that one for
question.
last, yeah.
Yeah, thank you for a little question. Okay. Mental health / behavioral. Okay, it is a huge cost driver for our state. We have underinvested in mental health and behavioral care for years and years and years. And where we are now, as we begin to assume risk for populations, there's a percentage of those that have issues. They're very expensive, and there's a lot of them in Medicaid. So because of our, in my opinion, because of our underinvestment in the mental health world, we have some catching up to do. We don't have enough providers, we don't have strategies to manage them, and it's a tough problem. So that's a long way of saying it has a dramatic impact on our system, and as we build these population-based but community-applied strategies, the Ida Grove, the Marshalltown strategy, it's start thinking about how do we do this here? Because in Ida Grove, there is a population that we know. Can we identify this group of people and work to help them be better so they don't spend all of our dollars? Same thing, so like in a community, there may be 10 or 15 people that have a certain problem. What if we figured out a community strategy on how we do this and cared for those people and kept them from crashing, kept them from having to come back to the hospital, kept them from having these problems? So it's kind of a proactive community approach.
Yeah, thanks, Tom. I know the hard thing about these questions is there's no simple answer, right? I mean,
No,
that's
there
kind of the deal. We would have solved this a long time ago if there was a simple answer.
I think there isn't a simple answer. There isn't a simple answer to any of this stuff. But because there's not a simple answer, we've kicked the can down the road for years and years and years. And we can't do it anymore. So now we actually have to build the new system. And we need to begin with the end in mind, healthier communities, good providers. So again, my challenge to everybody is let's start thinking about it for the good of Iowa. Let's figure out how we build a healthier state.
Yeah. Tom, thank you very much
okay.
for your time today and expertise. We really appreciate it.
Thank you.
All right. Hey, and thank you for those who have joined us online today. This will conclude the online portion of the event. But for those of you who are here in person, a couple things just to run by you. One of the things here is there's going to be a feedback survey at the bottom of your program, and we would really like to be able to have you fill that out and drop that off. There will be some foster group folks in the back of the room. They'll have baskets, and we'd love to get that from you so we can have programs that you think are worthwhile and ways that we can improve what we do. Also, as you leave today, I think I have these in my pocket. I do. These are investments. Someone gave these to me when I came in, and I thought, is that a hint? But anyway, there's some of these, so please pick those up as you go. Yeah. And we're going to be hosting a reception afterwards. There's a bar in the back for things to drink, and we're going to be opening some doors in the back of the room. There'll be things to eat behind there. We'd love to have you stick around. Thank you for coming today very much. We look forward to interacting with you here over the next little bit, and we'll see you soon. Thank you.
Okay.